Welcome to part 2 of this cardiology review. In the first video, we covered key concepts including intracellular calcium regulation and the role of the sodium-calcium exchanger in cardiac relaxation, the mechanism of action of potassium-sparing diuretics such as triamterene, and the clinical presentation of acute pericarditis associated with systemic conditions. In this second part, we will continue with Case 4 and Case 5, focusing on cardiac conduction disorders such as sick sinus syndrome, and important pharmacologic concepts related to calcium channel blockers and muscle physiology. Case 4. An elderly patient with recent lightheadedness and near syncope has an electrocardiogram showing bradycardia with drooped P waves. The question is, what is the most likely diagnosis in this patient? The correct answer is sick sinus syndrome. The second question in this case is cell degeneration. In which of the following locations is most likely responsible for this patient's current condition? The correct answer is right atrial wall. Sick sinus syndrome most commonly results from age-related degeneration of the sinoatrial node, which is located on the right atrial wall and is responsible for initiating normal cardiac conduction. Impaired signaling from the sinoatrial node can markedly slow the rate of ventricular contraction, leading to reduced cardiac output and symptoms of dyspnea, fatigue, lightheadedness, presyncope, and syncope. Electrocardiogram findings typically include bradycardia, sinus pauses, delayed P waves, sinus arrest, and prolonged delay of a P wave, such that the P wave is drooped. Case 5. A patient comes to the office for hypertension and coronary heart disease. He has been on several medications in the past with suboptimal blood pressure control. The physician considers adding verapamil to the patient's current regimen. For controlling systemic hypertension, verapamil also affects cardiac contractility but has a minimal effect on skeletal muscle. The question is, which of the following properties of skeletal muscle is responsible for its resistance to medication? The correct answer is little dependence on extracellular calcium influx. Calcium plays an important role in excitation-contraction coupling in cardiac, smooth, and skeletal muscle cells. Myocyte depolarization causes activation of L-type calcium channels on the plasma membrane in cardiac and smooth muscle cells. This leads to an influx of extracellular calcium that activates ryanodine receptor channels, inducing the release of additional calcium from the sarcoplasmic reticulum. In contrast, the L-type calcium channels in skeletal muscle directly interact with ryanodine receptor calcium channels to release calcium from the sarcoplasmic reticulum. This mechanical coupling allows sarcoplasmic calcium release to occur without significant influx of calcium across the plasma membrane. Thank you for watching this video. If you found it helpful, make sure to subscribe and stay connected to the channel. Your support helps keep this project growing and keeps me motivated to continue sharing content that helps all of us as medical students. The goal is to make the learning process more efficient and to support each other on the journey toward the USMLE steps. Welcome back to Easy Medicine. In this video, we are going to review several high-yield cardiology cases that are extremely important for Step 1 in clinical understanding. We will cover complete heart block and cardiac pacemakers, thiamine deficiency and wet beriberi, coronary artery bypass graft anatomy, ventricular septal defects, and the pathophysiology behind unilateral renal artery stenosis. These are the types of concepts that commonly appear in question banks and exams, but also help build a strong foundation in cardiovascular medicine. Let's get started. Case 1. A 67-year-old man is brought to the emergency department by his son after a syncopal episode. The son was helping his father clean out his garage when his father complained of dizziness. As his son was helping him into a chair, the patient lost consciousness. He woke up spontaneously about a minute later without any disorientation or confusion. Electrocardiogram demonstrates bradycardia with regular rhythm and narrow QRS complex. However, there is complete desynchronization between the P waves and QRS complex. The question here is, What is the location most likely responsible for pacing these patient ventricles? The correct answer is the atrioventricular node. The electrical impulses in the myocardium are normally generated by the sinoatrial node at a rate of 60 to 100 beats per minute. These impulses are then transmitted through the conduction system to the ventricles, which depolarize from apex to base and from endocardium to epicardium. Cells throughout the conduction system possess pacemaker ability. However, the sinoatrial node normally suppresses impulse generation by other cells because it fires more rapidly. If impulse conduction from the sinoatrial node becomes interrupted, the pacemaker activity of cells in other regions of the conduction system becomes unmasked. The location of the pacemaker can be identified on electrocardiogram, which reflects the sequence of cardiac depolarization. First comes atrial depolarization, represented by the P wave, followed by ventricular depolarization, represented by the QRS complex, and finally ventricular repolarization, represented by the T wave. AV nodal cells can become pacemakers when conduction between the sinoatrial node and the atrioventricular node is impaired. This occurs in complete third-degree atrioventricular block, in which impulses from the sinoatrial node continue to cause atrial contraction, while impulses generated by the atrioventricular node independently cause ventricular contraction. On electrocardiogram, the atria and ventricles depolarize independently of each other, a finding known as AV dissociation. The QRS complexes remain narrow because ventricular depolarization still proceeds normally through the conduction system. The atrioventricular node typically produces a heart rate of 45 to 55 beats per minute. Remember, cardiac pacemaker impulse generation normally occurs in the sinoatrial node because it has the fastest firing rate of all conductive cells. However, cells in other areas of the conduction system, including the AV node, bundle of His, and Purkinje fibers, may serve as pacemakers if normal impulse conduction becomes impaired. Case 2. A 78-year-old man comes to the office due to a 1-month history of progressive dyspnea, generalized weakness, fatigue, and palpitations. He also reports tingling and numbness in both lower limbs. His daughter, who is visiting from another state, adds that since his wife died a year ago, the patient has not been taking care of himself. Blood pressure is 105/50, and pulse is 104. Cardiovascular examination shows a displaced apical impulse at the 6th intercostal space, a third heart sound, and high-volume collapsing carotid pulses. Bilateral basal crackles, 2+ bilateral pedal edema, and mild hepatomegaly are also present. Neurologic examination shows decreased light touch and vibration sense in the feet, with decreased knee and ankle reflexes bilaterally. Laboratory evaluation shows normal blood counts. Deficiency of which nutrient is most likely responsible for this patient's condition? The correct answer is thiamine. Thiamine deficiency causes infantile and adult beriberi, as well as Wernicke-Korsakoff syndrome, which is characterized by confusion, ataxia, oculomotor abnormalities, and permanent memory deficits. Manifestations of infantile beriberi usually appear at age 2 to 3 months and include a fulminant cardiac syndrome with cardiomegaly, tachycardia, cyanosis, dyspnea, and vomiting. Adult beriberi is categorized as dry or wet depending on whether cardiac involvement is present. Dry beriberi is characterized by symmetrical peripheral neuropathy of the distal extremities, resulting in sensory and motor impairments. Wet beriberi includes cardiac involvement, leading to cardiomyopathy, high-output congestive heart failure, peripheral edema, and tachycardia. This patient demonstrates findings of both peripheral neuropathy and high-output heart failure, making wet beriberi the most likely diagnosis. Central nervous system involvement, such as Wernicke-Korsakoff syndrome, occurs primarily in alcoholics. Case 3. A 54-year-old man comes to the physician for evaluation of exertional chest pain. He first noticed the pain a couple months ago while shoveling snow off his driveway and has since experienced several episodes during other strenuous activities. He describes the pain as a heavy crushing sensation that is relieved with rest. Coronary angiography demonstrates severe stenosis of the right coronary artery, left anterior descending artery, and circumflex artery. The patient is referred for coronary artery bypass grafting. During the procedure, a portion of the great saphenous vein is removed and grafted to one of the diseased coronary arteries to bypass its atherosclerotic narrowing. The question is, where can this vein be accessed? The correct answer is just inferolateral to the pubic tubercle. When the left anterior descending artery alone is occluded, the left internal mammary artery is generally preferred because of superior long-term patency. However, when multiple coronary arteries require revascularization, great saphenous vein grafts are commonly used. The great saphenous vein is the longest vein in the body and is located superficially within the lower extremity. It courses superiorly from the medial foot, passes anterior to the medial malleolus, and continues along the medial aspect of the leg and thigh. In the proximal anterior thigh, approximately 3 to 4 cm inferolateral to the pubic tubercle, the great saphenous vein passes through the cribriform fascia at the saphenous opening and joins the femoral vein. Surgeons commonly access the great saphenous vein either along the medial leg or near its termination within the femoral triangle. The femoral triangle is bordered superiorly by the inguinal ligament, laterally by the sartorius muscle, and medially by the adductor longus muscle. Case 4. An 11-year-old boy comes to the office for a routine checkup prior to enrollment at summer camp. The patient is asymptomatic and has no complaints. Physical examination shows a well-appearing child. The lungs are clear to auscultation. Cardiac auscultation reveals a harsh hollow-systolic murmur heard best at the mid to lower left sternal border. The murmur intensifies with the hand grip maneuver. The question here is, what is the most likely diagnosis? The correct answer is ventricular septal defect. The clinical presentation of a ventricular septal defect depends primarily on the size of the defect. Large defects result in high-volume shunting of blood across the ventricular septum, producing a low interventricular pressure gradient and often a softer murmur. Excess blood flow can eventually lead to symptoms of heart failure during infancy. In contrast, small ventricular septal defects allow only limited blood flow across the defect. Most patients with small defects are asymptomatic and present with loud murmurs detected incidentally during routine examination. In this patient, the harsh hollow-systolic murmur heard at the mid to lower left sternal border is characteristic of a small hemodynamically insignificant ventricular septal defect. The hand grip maneuver increases systemic vascular resistance and therefore increases afterload. This increased resistance to forward blood flow results in greater left to right shunting across the ventricular septal defect, causing the murmur to become louder. Because the defect is hemodynamically insignificant, normal chest X-ray findings, normal electrocardiogram findings, and absence of right ventricular hypertrophy are expected. Case 5. A 62-year-old obese woman is brought to the hospital due to acute chest pain and shortness of breath. Her medical history includes hyperlipidemia, diet-controlled type 2 diabetes mellitus, and peripheral artery disease. 2 years ago, she had an ischemic stroke without residual neurologic deficits. The patient is also a current smoker with a 30-pack year history. After initial evaluation, she is taken to the cardiac catheterization laboratory, where she experiences cardiac arrest due to a ventricular arrhythmia and cannot be resuscitated. Autopsy reveals thrombotic occlusion of the left anterior descending artery. In addition, there is 95% atherosclerotic narrowing of the proximal right renal artery, with no significant stenosis of the left renal artery. Compared with the right kidney, what finding is more likely to be present in the left kidney? The correct answer is arteriolar wall thickening. These findings are consistent with severe unilateral renal artery stenosis, which most commonly occurs in older individuals due to atherosclerosis. Hypoperfusion of the stenotic right kidney stimulates renin release from the juxtaglomerular apparatus. Renin converts angiotensinogen into angiotensin I, which is then converted by angiotensin-converting enzyme into angiotensin II, a potent vasoconstrictor that produces systemic hypertension. Unilateral renal artery stenosis produces very different morphologic changes in the stenotic kidney compared with the contralateral non-stenotic kidney. The stenotic right kidney experiences chronic hypoperfusion and ischemia, leading to diffuse cortical thinning, tubular atrophy, interstitial fibrosis, and small crowded glomeruli. Chronic stimulation of the juxtaglomerular apparatus can also produce enlargement due to persistent renin release. In contrast, the non-stenotic left kidney is exposed to elevated systemic blood pressure. As a result, it develops findings consistent with hypertensive nephrosclerosis, including arteriolar wall thickening due to hyaline arteriolosclerosis, hyalinization caused by plasma protein leakage, and hyperplastic arteriolosclerosis characterized by concentric smooth muscle proliferation in response to elevated pressure. If you found this video helpful, make sure to subscribe to Easy Medicine for more high-yield medical concepts made simple. We regularly cover cardiology, pathology, psychiatry, physiology, pharmacology, and Step 1 style clinical cases designed to help you study faster and understand medicine more clearly. Thanks for watching, and I'll see you in the next video. Cardiac physiology and ECG concepts. Cardiac myocyte action potential at rest, approximately 90 millivolts, inside. Potassium, K, outside. Sodium, Na, and calcium, Ca², phases. Phase 0. Na influx right pointing arrow depolarization phase 1. Brief K efflux phase 2. Ca² influx plus K efflux right pointing arrow plateau phase 3. K efflux right pointing arrow repolarization depolarization right pointing arrow Na influx phase 4. Return to resting potential neuron action potential. Key concept, repolarization right pointing arrow K efflux right finger in repolarization phase. P Na less than PK membrane potential. Question concept, resting membrane potential, approximately 70 millivolts, is closest to K equilibrium potential. Main determinant, high K conductance plus small Na leak. Pacemaker ECG interpretation. Sharp vertical spikes equals pacemaker activity. Key idea, pacemaker spikes equals artificial electrical stimulation before heart contraction. Spike before P wave right pointing arrow atrial pacing. Spike before QRS right pointing arrow ventricular pacing. Right finger both present right pointing arrow dual chamber pacemaker. MRI in pacemaker patients. Check if device is MRI conditional reprogram device before MRI monitor during procedure. Recheck and restore settings after psychiatry. Core concepts, dopaminergic pathways. Mesolimbic right pointing arrow positive symptoms, hallucinations, delusions. Mesocortical nigrostriatal tuberoinfundibular right pointing arrow prolactin regulation. Right finger blockade right pointing arrow amenorrhea plus galactorrhea. In this video, we review high-yield clinical cases focused on cardiology and cardiovascular physiology. We will analyze topics ranging from transplant rejection to hemodynamics, adrenergic pharmacology, and valvular disease. The goal is to integrate key concepts clearly for clinical application and exam preparation. Okay, so we have a 15-year-old male who suffered severe cardiomyopathy and has a cardiac transplant. 2 weeks following his cardiac transplantation, he is experiencing dyspnea on exertion. The question here is, which of the following findings is most consistent with acute graft rejection? The correct answer is dense interstitial lymphocytic infiltrate. Acute rejection occurs in approximately 2 of every 5 heart transplants, and the large majority of cases occur through a cell-mediated pathway. The key clue that indicates the patient is experiencing acute rejection is the time frame of symptoms, which is 2 weeks post-transplant, because acute rejection usually occurs between 1 and 4 weeks following transplantation. Histopathology most consistent with acute rejection shows a dense infiltrate of mononuclear cells, primarily composed of T lymphocytes. Acute cellular rejection of a transplant organ is mediated by host T lymphocyte sensitization against graft or foreign major histocompatibility complex, MHC, antigens. Case 2. A patient is undergoing exercise treadmill stress testing. The question here is, Which of the following parameters is most likely decreased during peak stress compared to the resting state? The correct answer is total systemic vascular resistance. Stimulation in exercising muscle causes sympathetic activation and withdrawal of vagal tone, resulting in increased heart rate, stroke volume, and overall cardiac output. At higher levels of exercise, heart rate is predominantly responsible for most of the increase in cardiac output. Sympathetic discharge causes contraction of arterioles in all tissues except the actively working muscle, effectively shunting blood toward the exercising muscle. This results in increased systolic blood pressure, improving perfusion of actively contracting skeletal muscle. However, the rise in mean arterial pressure is much lower due to an overall decrease in systemic vascular resistance. Case 3. A 67-year-old man is found dead at home. An autopsy is performed. The patient had a history of hypertension and a myocardial infarction 1 year ago. Gross examination of the heart shows white scarring and enlargement of the left ventricle. The question is, which type of collagen found in this autopsy sample is also extensively found in which of the following normal body tissues? The correct answer is tendon. There are 4 main types of collagen. Type 1 collagen, found in skin, bone, tendons, ligaments, dentin, cornea, blood vessels, and scar tissue. Type 2 collagen, found in cartilage, vitreous humor, and nucleus pulposus. Type 3 collagen, found in skin, lungs, intestines, blood vessels, bone marrow, lymphatics, and granulation tissue. Type 4 collagen, found in basement membranes. Continuing with this high-yield cardiology review, we will now focus on myocardial infarction evolution, key pharmacologic effects of alpha-adrenergic agonists, and important clinical scenarios involving hemodynamics and cardiac function. These concepts are essential for both exams and real clinical understanding. Evolution of myocardial infarction occurs in several stages. The final stage of healing begins approximately 2 weeks after infarction and involves increasing deposition of type 1 collagen. Fibrosis continues until about 2 months after infarction, resulting in a dense collagenous scar composed primarily of type 1 collagen. This scar can be identified grossly as a firm gray-white lesion and microscopically as collagen replacing normal myocardium. Time after myocardial infarction and predominant light microscopic changes. 0 to 4 hours no visible change. 4 to 12 hours wavy fibers with narrow, elongated myocytes. 12 to 24 hours myocyte hyperiocinophilia with pycnotic nuclei. 1 to 3 days coagulation necrosis with loss of nuclei and striations. Prominent neutrophilic infiltrate. 3 to 7 days disintegration of dead neutrophils and myofibers. Macrophage infiltration at border areas. 7 to 10 days robust phagocytosis of dead cells by macrophages beginning formation of granulation tissue at margins. 10 to 14 days well-developed granulation tissue with neovascularization. 2 to 8 weeks progressive collagen deposition and scar formation. Direct effects of alpha-adrenergic agonists. Alpha-1 mediated effects vascular smooth muscle contraction mydriasis increased internal urethral sphincter tone and prostate contraction. Alpha-2 mediated effects central nervous system mediated decrease in blood pressure decreased intraocular pressure decreased lipolysis decreased presynaptic norepinephrine release increased platelet aggregation. Case 4. A patient receives a drug that increases systolic and diastolic blood pressure with a reflex decrease in heart rate. These findings are consistent with a selective alpha-1 adrenergic agonist such as phenylephrine or methoxamine. The correct answer is decreased atrioventricular node conduction velocity. Activation of alpha-1 receptors in vascular smooth muscle causes vasoconstriction and increased systemic blood pressure. This increase is detected by baroreceptors located in the carotid sinus and aortic arch. Baroreceptor activation leads to increased vagal tone. This results in decreased firing of the sinoatrial node, slowed conduction through the atrioventricular node, and reduced myocardial contractility. This explains the reflex bradycardia seen after administration of alpha-1 agonists. Case 5. A patient with hypertension, diabetes mellitus, and hypercholesterolemia presents with decreased left ventricular function. Echocardiogram shows hypokinesia of the anterior wall and a reduced left ventricular ejection fraction of 35%. After coronary artery bypass grafting, the hypokinesia resolves and the ejection fraction improves to 50%. The correct answer is hibernating myocardium. Myocardial hibernation is a state of chronic ischemia in which myocardial metabolism and contractile function are reduced to match decreased coronary blood flow due to significant stenosis. This adaptive mechanism prevents irreversible myocardial injury. At the cellular level, there is decreased expression and disorganization of contractile proteins, altered adrenergic signaling, and reduced calcium responsiveness. These changes lead to decreased contractility and systolic dysfunction. Importantly, restoration of blood flow through revascularization allows recovery of myocardial function, explaining the improvement seen after surgery. Case 6. A patient undergoes surgery and afterward demonstrates a rightward shift in end diastolic volume on the pressure volume loop, indicating increased preload. This hemodynamic change can occur with infusion of normal saline, blood transfusion, or conditions such as renal failure that increase intravascular volume. The correct answer is normal saline infusion. In this final segment, we will continue building on previous concepts by reviewing valvular heart disease, pericardial pathology, vascular physiology, and complications related to cardiac devices. These cases will help reinforce pattern recognition and clinical reasoning. Case 7. A patient presents with an opening snap followed by a low-pitched, rumbling diastolic murmur best heard at the cardiac apex. This is characteristic of mitral stenosis. Mitral stenosis is most commonly caused by rheumatic heart disease, especially in patients from Latin America, Africa, or Asia. The opening snap occurs due to abrupt opening of a stenotic and calcified mitral valve. This sound is followed by a diastolic murmur caused by turbulent flow across the narrowed valve during ventricular filling. On the left ventricular pressure volume loop, this event occurs at the end of isovolumetric relaxation, when the mitral valve opens. This corresponds to the transition into diastolic filling. Case 8. A 28-year-old man presents with a 3-day history of chest tightness and intermittent sharp chest pain. He also reports mild dyspnea, especially with exertion. He has no chronic medical conditions but had a recent upper respiratory infection that resolved without treatment. Electrocardiogram shows sinus tachycardia and low-voltage QRS complexes with variation in amplitude, known as electrical alternance. The diagnosis is viral pericarditis complicated by pericardial effusion. Chest X-ray may show an enlarged cardiac silhouette with clear lung fields. Pericardial effusion can be caused by acute pericarditis, cardiac injury such as myocardial infarction or surgery, malignancy, or renal failure with uremia. Clinical features include dyspnea, chest discomfort, and fatigue. In severe cases, cardiac tamponade may occur, presenting with hypotension, jugular venous distension, and decreased heart sounds. A patient receives acetylcholine during a procedure, resulting in dilation of epicardial coronary vessels. The correct answer is arginine. Endothelial cells respond to acetylcholine and other stimuli by increasing intracellular calcium levels, which activates endothelial nitric oxide synthase. Nitric oxide is synthesized from arginine, nicotinamide adenine dinucleotide phosphate, and oxygen. It then diffuses into vascular smooth muscle cells, activating guanylyl cyclase and increasing cyclic guanosine monophosphate levels. Elevated cyclic guanosine monophosphate activates protein kinase G, leading to decreased intracellular calcium and smooth muscle relaxation, resulting in vasodilation. Case 10. An 82-year-old man presents with fatigue, abdominal discomfort, and lower extremity swelling. He also reports a pulsating sensation in his neck. 6 weeks earlier, he underwent pacemaker implantation for sick sinus syndrome. Physical examination reveals bilateral lower extremity edema and a tender, pulsatile liver. The most likely diagnosis is tricuspid valve regurgitation due to mechanical disruption caused by the pacemaker lead. The lead passes from the superior vena cava into the right atrium and across the tricuspid valve into the right ventricle. This can interfere with valve leaflet coaptation or directly damage the valve. Severe tricuspid regurgitation leads to right-sided heart failure, characterized by jugular venous distension, hepatomegaly, ascites, and peripheral edema. On auscultation, a hollow systolic murmur is heard best at the left lower sternal border. This murmur becomes louder with maneuvers that increase right ventricular preload, such as deep inspiration or leg elevation. Introduction. In this video, we will review 5 high-yield cardiology cases focused on physiology, pharmacology, and clinical correlations. Each case is designed to reinforce key concepts tested in medical exams and to help you build a stronger understanding through concise and practical explanations. Case 1: A physiology study has a diseased heart for intracellular calcium regulation. Microelectrodes placed into cardiac muscle cells detect a rapid decrease in cytoplasmic calcium level immediately preceding relaxation. The question in this case is which of the following proteins is most likely responsible for the observed change in electrolyte levels. The correct answer is sodium-calcium exchanger. Intracellular calcium regulation plays an important role in excitation-contraction coupling. Voltage-dependent calcium channels, L-type, are activated during phase 2 of cardiac action potential depolarization and permit influx of calcium into the cardiac myocytes. The final stage of excitation-contraction coupling is myocyte relaxation, which occurs subsequent to the calcium efflux from the cytoplasm. Intracellular calcium is removed primarily via a sodium-calcium exchange pump and sarcoplasmic reticulum calcium ATP-ACE pump. Case 2. A patient that comes to the emergency department is initiating a new treatment based on his most recent laboratory results. This treatment is triamterene. The question here is which of the following best describes the mechanism of action of this medication. The correct answer for this case is blocking renal tubular epithelial sodium channels. The thiazide diuretics lower blood pressure by inhibiting the sodium chloride counterporter in the distal convoluted tubules, thereby decreasing reabsorption of sodium and chloride. Both the thiazide and loop diuretics induce volume loss with subsequent activation of the renin-angiotensin-aldosterone system. Aldosterone increases renal sodium resorption in exchange for potassium by upregulating the synthesis and activity of epithelial sodium channels and sodium-potassium ATP-ACE pump. Because of these effects, increased aldosterone levels commonly result in hypokalemia, which can lead to muscle cramps, weakness, and, when severe, cardiac arrhythmias. Potassium-sparing diuretics may be added to prevent hypokalemia. These weak diuretic medications act in the distal nephron, where they reduce potassium excretion. Triamterene and amiloride directly inhibit the epithelial sodium channel, preventing sodium from entering principal cells. This reduces the electrochemical gradient that helps drive potassium secretion. Case 3. A 30-year-old woman comes to the emergency department for sharp chest pain that radiates to the left shoulder. This pain increases with inspiration and is relieved by sitting up and leaning forward. She was seen for a facial rash 6 months ago. She has also been evaluated for proteinuria that was identified during her last clinic appointment. The question in this case is what is the most likely cause of this patient's chest pain? The correct answer for this case is pericardial inflammation. This patient's chest pain is characteristic of acute pericarditis, which, along with her facial rash and proteinuria, is suggestive of underlying systemic lupus erythematosus. Systemic lupus erythematosus is a chronic autoimmune disease predominantly affecting women aged 20 to 40 that causes constitutional and multisystemic symptoms. Serositis inflammation is common and most often manifests as pleuritis or pericarditis. This is only the first part of this cardiology review. In the next video, we will continue with Case 4 and Case 5, covering more high-yield concepts you need to know. Make sure to check the link and continue learning with Part 2. In this video, we will review high-yield cardiovascular concepts through 5 clinically relevant cases commonly tested on the USMLE Step 1. These cases integrate key principles of hemodynamics, vascular anatomy, cardiac physiology, and pharmacology. We will explore how changes in vessel radius affect blood flow, the clinical implications of renal vein compression, pressure changes seen in valvular heart disease, essential landmarks for vascular access, and the mechanisms behind common cardiac medications and their toxicities. The goal of this video is to help you connect physiology with clinical scenarios, making complex concepts easier to understand, retain, and apply during your exam. Case 1. A 63-year-old man with long-standing hypertension undergoes a CT scan of the lumbar spine, which incidentally reveals a small right kidney. Angiography demonstrates atherosclerotic narrowing of the right renal artery, while the left renal artery remains intact. Blood flow in the right renal artery is decreased by a factor of 16 compared to the left. The question is, by what percentage has the radius of the lumen been reduced? The correct answer is 50%. Blood flow through a vessel is determined by the pressure gradient divided by the resistance to flow. According to Poiseuille's equation, resistance is inversely proportional to the fourth power of the vessel radius. This means that even a small decrease in radius produces a large increase in resistance and a significant decrease in flow. In this patient, flow is reduced by a factor of 16. Assuming all other variables remain constant, this corresponds to the radius being reduced to 1/2 of its original size. Therefore, the lumen radius has decreased by 50%. Case 2. A 20-year-old man presents with hematuria and intermittent left flank pain for several months. Urinalysis shows 3+ blood, with no white blood cells, crystals, or organisms. A CT scan reveals no abnormalities in the kidneys or ureters, but shows compression of the left renal vein between the superior mesenteric artery and the aorta. The question is, what vascular abnormality is most likely to develop in this patient? The correct answer is varicocele. Anatomically, the right renal vein is short and drains directly into the inferior vena cava. The right gonadal vein also drains directly into the inferior vena cava. In contrast, the left renal vein is longer and passes between the aorta and the superior mesenteric artery before draining into the inferior vena cava. The left gonadal vein drains into the left renal vein. Compression of the left renal vein between the aorta and the superior mesenteric artery increases venous pressure. This is known as the nutcracker effect. Persistent elevation of pressure can lead to left renal vein entrapment syndrome, causing flank pain and hematuria. Increased pressure is transmitted to the left gonadal vein, leading to valvular failure and dilation of the pampiniform plexus. This results in a varicocele, most commonly on the left side. Case 3. A 50-year-old man presents with exertional dyspnea and fatigue. He also reports difficulty breathing at night and requires multiple pillows to sleep. He has occasional palpitations but no chest pain. He undergoes left heart catheterization, which shows pressure changes consistent with mitral regurgitation. During the cardiac cycle, the left atrium fills passively with blood from the pulmonary veins during atrial diastole, which occurs simultaneously with left ventricular systole. In a normal heart, left atrial pressure gradually increases to about 10 mm of mercury, forming a characteristic V wave at the end of passive filling. In mitral regurgitation, the mitral valve is incompetent, allowing blood to flow backward from the left ventricle into the left atrium during systole. This causes a marked increase in left atrial pressure during ventricular contraction. As a result, there is an early and prominent V wave on the pressure tracing, which is the characteristic finding in mitral regurgitation. In this second part, we continue building on the cardiovascular concepts introduced earlier, now focusing on applied anatomy and clinical pharmacology. In these final cases, we will review key landmarks for safe vascular access and analyze a classic presentation of medication toxicity in a patient with cardiac disease. These scenarios are essential for understanding how anatomy and pharmacologic mechanisms translate directly into clinical decision-making, a critical skill for the USMLE Step 1. Case 4. A patient requires femoral venous access for administration of intravenous fluids and antibiotics. The femoral artery pulse is palpated just below the inguinal ligament. The question is, what is the optimal site for femoral vein cannulation? The correct answer is immediately medial to the femoral artery. Femoral vein catheterization is commonly performed when other access sites, such as the subclavian or internal jugular veins, are unavailable or contraindicated. It is also used in emergency situations. The femoral vein is the main deep vein of the lower extremity. It passes through the femoral triangle beneath the inguinal ligament and continues as the external iliac vein. The femoral triangle is bordered superiorly by the inguinal ligament, medially by the adductor longus muscle, and laterally by the sartorius muscle. Within this triangle, the structures are arranged from lateral to medial as follows: nerve, artery, vein, and lymphatics. Therefore, the femoral vein lies immediately medial to the femoral artery, making this the ideal site for cannulation. Case 5. A 70-year-old woman with persistent atrial fibrillation and congestive heart failure is taking multiple medications. She presents with nausea, decreased appetite, and 3 episodes of vomiting. Her vital signs are normal. An electrocardiogram shows a junctional escape rhythm at a rate of 48 beats per minute with occasional premature ventricular beats. The question is, increased levels of which medication are most likely responsible for her symptoms? The correct answer is digoxin. This patient presents with signs and symptoms of digoxin toxicity. Although calcium channel blockers and beta blockers are first-line treatments for atrial fibrillation with rapid ventricular response, digoxin is often used as a second-line agent, especially in patients with systolic heart failure. Digoxin works by increasing vagal tone, which slows conduction through the atrioventricular node, producing a rate control effect. It also inhibits the sodium-potassium ATPase pump, leading to increased intracellular sodium and calcium, which enhances cardiac contractility. However, digoxin has a narrow therapeutic index, making toxicity relatively common. Symptoms of toxicity are often nonspecific and include nausea, vomiting, abdominal pain, fatigue, dizziness, confusion, blurred vision, and changes in color perception. Cardiac manifestations include bradycardia, atrioventricular block, and junctional escape rhythms. Hypokalemia increases the risk of toxicity by enhancing digoxin binding to the sodium-potassium ATPase. Thank you for watching this video. This channel is designed to help medical students simplify complex topics into high-yield concepts that are easier to understand and remember. All the content is based on trusted medical resources such as question banks and standard USMLE material, with the goal of helping you study more efficiently, especially during moments when you would normally not be studying, like driving or waiting. This is not a complete study resource, but a complementary tool to reinforce key concepts and improve retention over time. If you find this content helpful, consider subscribing to the channel and turning on notifications so you do not miss upcoming videos. New content is focused on high-yield topics across multiple systems to support your preparation for the USMLE Step exams. Your support helps keep this project growing and allows me to continue creating more content for students like you.
In this video, we will review high-yield cardiology cases focused on arrhythmias, volume physiology, and heart sounds. These concepts are essential for understanding clinical scenarios and improving your performance on medical exams. Let's get started with Case 1. Case 1. A 20-year-old man comes to the emergency department with chest heaviness and palpitations for the last 3 hours. Over the past year, he had a similar episode that resolved with deep breathing, but it did not last as long as this one. He does not use tobacco, alcohol, caffeine, or illicit drugs. Blood pressure is 100/70 millimeters of mercury, and pulse is 160 beats per minute and regular. The neck is supple, the thyroid is normal, and there is no lymphadenopathy. Electrocardiogram reveals a narrow QRS complex tachycardia with irregular rhythm and non-visible P waves. These findings are consistent with paroxysmal supraventricular tachycardia, also known as PSVT. The most likely cause of this patient's symptoms is abnormal conduction through the atrioventricular node. Paroxysmal supraventricular tachycardia originates at or above the atrioventricular node. The most common type is atrioventricular nodal reentrant tachycardia, which usually affects young patients under 40 years of age with otherwise normal hearts. These patients have two distinct AV nodal conduction pathways: a fast pathway with a long refractory period, and a slow pathway with a short refractory period. On electrocardiogram, retrograde conduction up the fast pathway creates a retrograde P wave. However, because this conduction is usually simultaneous with anterograde conduction to the ventricles, the P wave is often buried within the QRS complex and is not visible. Case 2. In this experiment, 3 liters of isotonic saline are infused intravenously into a healthy volunteer. Serial blood pressure measurements show an increase in both systolic and diastolic blood pressure. Ultrasonography reveals an increase in left ventricular volume and engorgement of the inferior vena cava. Blood levels of a peptide hormone are also increased compared to baseline. This hormone most likely increases the glomerular filtration rate. Intravenous infusion of isotonic saline leads to intravascular volume expansion, which increases intracardiac volume and filling pressures. This results in myocardial wall stretch and triggers the release of endogenous natriuretic peptides, including atrial natriuretic peptide and brain natriuretic peptide, from the atria and ventricles. Both peptides activate guanylate cyclase, increasing intracellular cyclic GMP and producing physiologic effects in multiple tissues. In the kidney, natriuretic peptides promote dilation of the afferent arteriole and constriction of the efferent arteriole, leading to an increased glomerular filtration rate. This results in increased sodium excretion and diuresis. Additionally, these peptides inhibit proximal tubular sodium reabsorption and decrease renin secretion, which reduces angiotensin II and aldosterone levels, further enhancing natriuresis and diuresis. Case 3. A 60-year-old man with a long history of hypertension and type 2 diabetes presents for evaluation. He is an ex-smoker with a 15-pack year history and jogs 3 miles per day. His BMI is 29. Cardiac auscultation reveals an extra low-frequency heart sound at the end of diastole, just before S1. This is known as the fourth heart sound, or S4. This finding is best explained by left ventricular hypertrophy. The S4 sound is commonly heard in older adults due to decreased left ventricular compliance and may sometimes be benign. However, when the sound is more prominent, it usually indicates a pathologic stiff left ventricle, which can occur in restrictive cardiomyopathy or in left ventricular hypertrophy due to prolonged hypertension. The S4 occurs during atrial contraction and is produced by the forceful movement of blood into a stiff, non-compliant left ventricle. Here is your continuation of high-yield cardiology cases. In this second part, we will cover acute myocardial infarction and its long-term management, reflex-mediated syncope, and congenital causes of cyanosis in newborns. These are key concepts that frequently appear in clinical practice and exams. Let's continue with Case 4. A 60-year-old man presents with 24 hours of burning substernal chest pain. The most intense pain occurred 8 hours ago and has started to subside. Electrocardiogram shows ST segment elevation in leads V3 to V5. There is total occlusion of the left anterior descending artery. Successful intervention restores blood flow. Echocardiogram shows a normal-sized left ventricle with no hypertrophy, but there is apical and anterior akinesia and a reduced ejection fraction of 38%. The most likely long-term effect of ACE inhibitor therapy in this patient is attenuation of left ventricular chamber dilation. Following myocardial infarction, the affected myocardium undergoes fibrosis and remodeling. The infarcted area may thin and dilate, leading to enlargement of the left ventricular cavity. Initially, this compensates for volume overload, but progressive dilation increases wall stress and worsens contractile function. This remodeling process is partly driven by angiotensin II. ACE inhibitors, such as lisinopril, reduce this maladaptive remodeling, minimize ventricular dilation, and help preserve cardiac function. Case 5. A 72-year-old man presents with episodic lightheadedness. These episodes occur in the morning when he adjusts his shirt collar or tightens his tie. He briefly feels like he is going to pass out. He has a history of thyroidectomy and hypertension. Physical examination and ECG are normal. He is given an ambulatory ECG monitor. The most likely finding is a sinus pause. This patient has carotid sinus hypersensitivity. This condition results from overly sensitive carotid baroreceptors that trigger an exaggerated vagal response when stimulated. This leads to increased parasympathetic output, causing a prolonged sinus pause of several seconds, and decreased sympathetic tone, resulting in vasodilation. The combination reduces cardiac output and cerebral perfusion, leading to presyncope or syncope. Case 6. A newborn develops cyanosis 4 hours after birth. Pulse oximetry shows higher oxygen saturation in the right hand compared to the left foot. The infant has subcostal retractions, grunting, and a systolic murmur. The cause of this cyanosis is a right-to-left shunt through a patent ductus arteriosus. Differential cyanosis indicates that deoxygenated blood is flowing from the pulmonary artery into the aorta. This pattern is commonly seen in persistent pulmonary hypertension of the newborn or left-sided obstructive lesions.
Welcome back to Easy Medicine. In this part, we continue with high-yield cardiology cases focusing on acute myocardial infarction complications and critical pharmacologic management. These are key concepts you need to recognize fast on exam day. Case 3. A 55-year-old man comes to the emergency department due to 1 hour of intense epigastric chest pain accompanied by sweating. He has obesity and diet-controlled type 2 diabetes mellitus. An immediate electrocardiogram shows normal sinus rhythm with 2 mm of ST segment elevation in leads 2, 3, and AVF. Aspirin and morphine are administered. Blood pressure is 110/70 mm of mercury, pulse is 60 beats per minute and regular, and oxygen saturation is 98% on room air. After administration of aspirin and morphine, the patient is transported to the catheterization lab for urgent percutaneous coronary intervention. He develops dizziness, and the telemetry monitor shows sinus bradycardia at 40 beats per minute. The patient appears pale and diaphoretic, and peripheral pulses are faint. Blood pressure is 70/40 mm of mercury. The question is, What is the most appropriate immediate step for managing this patient's condition? The correct answer is atropine. This patient with ST elevation in leads 2, 3, and AVF has an acute inferior wall myocardial infarction, which most commonly occurs due to occlusion of the right coronary artery. The right coronary artery usually supplies blood to the sinoatrial node, the atrioventricular node, and most of the bundle of His. Therefore, conduction impairment, sinus bradycardia, and atrioventricular block are common in patients with inferior wall myocardial infarction. Sinus bradycardia is the most common arrhythmia in these patients. It occurs due to both nodal ischemia and enhanced vagal tone triggered by infarction of myocardial tissue. Although the bradycardia is usually transient and resolves with restoration of coronary blood flow, patients with hypotension or symptoms such as lightheadedness or syncope should be managed with intravenous atropine. The anticholinergic effects of atropine counteract the enhanced vagal tone, increasing heart rate and improving symptoms. Case 4. A 40-year-old female with a history of depression and hypertension is brought to the emergency room after being found obtunded in her apartment. She is hypotensive and bradycardic on physical examination. Intravenous glucagon is administered, and her condition improves. The question is, which intracellular change is most likely responsible for this improvement? The correct answer is increased cyclic AMP in cardiac myocytes. This patient most likely overdosed on a beta blocker medication. Beta blocker overdose causes diffuse non-selective blockade of peripheral beta-adrenergic receptors, leading to depression of myocardial contractility, bradycardia, and decreased atrioventricular conduction, resulting in a low cardiac output state. Glucagon is the drug of choice for beta blocker overdose. It acts on G protein-coupled receptors, increasing intracellular cyclic AMP and enhancing calcium availability during muscle contraction. This results in increased heart rate and cardiac contractility. Clinical improvement in heart rate and blood pressure can be observed within minutes. Importantly, glucagon works independently of adrenergic receptors. In the next and final part, we will cover more high-yield concepts including stroke mechanisms and coronary artery disease adaptations. Make sure to watch Part 3 to complete the full cardiology review. You are watching Easy Medicine, your go-to resource for high-yield concepts made simple. In this video, we will break down 2 key cardiology cases that you must know for Step 1, focusing on pressure-volume relationships and cardiac tumors. Let's get started. Case 1. In this case, we are going to show the ventricular pressure-volume relationship that affects the therapy of sodium nitroprusside infusion. We have a 45-year-old man who comes to the emergency department due to a 2-day history of dyspnea, orthopnea, and ankle swelling. This morning, he also had nausea, vomiting, and headache. Blood pressure is elevated, and physical examination shows pulmonary crackles and bilateral pitting edema up to the knees. Sodium nitroprusside infusion is begun. The question is, what is the left ventricular pressure-volume relationship that represents the effects of this therapy? The solid line is before nitroprusside, and the dashed line is during nitroprusside infusion. The correct answer is the picture that is shown in the window. The explanation of this case is that this patient most likely has acute heart failure due to systemic hypertension, which can be treated with an infusion of sodium nitroprusside. Sodium nitroprusside is a short-acting agent that causes balanced vasodilation of the veins and arteries. As such, it decreases ventricular preload and afterload, allowing for maintenance of cardiac output. At a lower left ventricular pressure, contractility is essentially unchanged. Of the choices given, only the graph in the image shows a reduction in both left ventricular end diastolic volume, that is preload, and left ventricular systolic pressure, that is afterload, without a decrease in contractility. Case 2. A 30-year-old man is presented to the emergency department due to left-sided weakness. The patient has no known medical conditions but has a 2-month history of positional dyspnea. Vital signs are within normal limits. The strength of the left upper and left lower extremities is reduced, and touch and temperature sensation are similarly diminished. Cardiovascular examination reveals an intermittent murmur at the apex without carotid bruit. Echocardiography shows a mobile 3 cm left atrial mass obstructing the mitral opening during diastole. The patient undergoes histologic examination of the mass. The question is, what are the findings in this histologic examination? The correct answer is amorphous extracellular matrix. This patient's left atrial mass on echocardiography is consistent with an atrial myxoma, the most common primary benign cardiac neoplasm. Approximately 80% originate in the left atrium, and they can present with systemic embolization, such as a stroke, as in this patient, due to tumor fragments passing into the systemic circulation. The tumor may also lead to constitutional symptoms such as fatigue, weight loss, and low-grade fever resulting from cytokine release. In addition, it can cause transient mitral valve obstruction, leading to symptoms that mimic mitral valve stenosis, including dyspnea or hemoptysis. Physical examination often reveals an intermittent or positional mid-diastolic murmur known as a tumor plop, which results from the motion of the tumor mass obstructing the mitral valve orifice. Histopathologic examination of the myxoma reveals amorphous extracellular matrix with scattered stellate or globular myxoma cells within abundant mucopolysaccharide myxoid ground substance containing chondroitin sulfate and hyaluronic acid. Due to their high vascularity, these tumors often demonstrate areas of hemorrhage accompanied by brown hemosiderin-laden macrophages. If you found this helpful, the next part continues with more high-yield cardiology cases, including myocardial infarction complications and critical emergency management. Make sure to watch Part 2 to complete the full review.
In this final part, we will review key high-yield cardiology cases focused on heart failure management, pericardial disease, conduction abnormalities, and genetic causes of sudden cardiac death. These topics are essential for clinical reasoning and frequently tested in medical exams. Let's continue with Case 7. A 69-year-old man presents with progressive dyspnea and leg swelling. He has a history of lymphoma treated with chemotherapy. Echocardiogram shows biventricular dilation and an ejection fraction of 35%. The appropriate long-term therapy to improve survival is carvedilol. This patient has systolic heart failure due to non-ischemic cardiomyopathy. Beta blockers, such as carvedilol, improve survival in heart failure with reduced ejection fraction. Case 8. A 33-year-old woman presents with sharp chest pain that worsens with inspiration and improves when leaning forward. She recently had an upper respiratory infection. The expected finding is a pericardial friction rub. This is acute pericarditis, most commonly caused by viral infection. The friction rub is a high-pitched, scratchy sound and is the most specific physical finding. Case 9. A 15-year-old boy presents with palpitations. Electrocardiogram shows a Wolff-Parkinson White pattern. This is due to an accessory conduction pathway known as the bundle of Kent, which bypasses the atrioventricular node and causes pre-excitation. Case 10. A 20-year-old man suddenly collapses and dies. Genetic testing reveals a mutation in the TTN gene resulting in a truncated titin protein. The most likely finding is dilated cardiomyopathy. This condition leads to ventricular dilation and systolic dysfunction and increases the risk of sudden cardiac death due to arrhythmias.
Welcome back to Easy Medicine. This is the final part of our high-yield cardiology case series, where we will cover key concepts on stroke mechanisms and coronary artery disease adaptations. Let's finish strong. Case 5. A 37-year-old woman is brought to the emergency department after developing sudden-onset right arm weakness and difficulty speaking. She has no medical history but takes oral contraceptives. She has decreased strength in the right upper extremity and expressive aphasia. Cardiac auscultation is normal. Magnetic resonance imaging of the brain reveals an acute infarction in the left frontal lobe. Further evaluation with echocardiography is performed. Agitated normal saline is injected into a peripheral vein, and bubbles are seen passing into the left side of the heart. The question is, what is the most likely cause of this finding? The correct answer is incomplete fusion of the atrial septum primum and secundum. This patient had a cryptogenic stroke, which is evaluated using a bubble study to identify right to left intracardiac shunts. The test involves injecting agitated saline intravenously and observing for microbubbles in the left heart. Detection is improved with a Valsalva maneuver, which increases right atrial pressure. Cryptogenic stroke is frequently associated with atrial septal abnormalities such as patent foramen oval. During fetal development, the foramen oval allows blood to flow from the right atrium to the left atrium. After birth, changes in pressure cause closure of this opening as the septum primum is pushed against the septum secundum. Over time, fibrosis leads to permanent closure. However, incomplete fusion occurs in approximately 25% of adults, resulting in a patent foramen oval. Case 6. A 69-year-old man comes to the clinic due to squeezing pressure in his midline chest and neck that occurs when walking. He has hypertension and type 2 diabetes mellitus. He is an ex-smoker with a 20-pack year history. Coronary angiography shows extensive atherosclerosis and near total occlusion of the left anterior descending artery. Despite this, he has a normal resting left ventricular ejection fraction and no regional wall motion abnormalities. The question is, what explains the absence of myocardial necrosis and scarring? The correct answer is slow growth rate of the plaque. In response to progressive reduction in blood flow, ischemic myocardium releases growth factors such as vascular endothelial growth factor, which stimulate the development of collateral vessels. In this patient, the slow development of a stable atherosclerotic plaque allowed collateral vessels from the right coronary artery to supply the myocardium distal to the occlusion. Because hydrostatic pressure distal to the occlusion is low, a pressure gradient facilitates blood flow through these collateral vessels. In contrast, unstable plaques are more likely to rupture suddenly, leading to acute thrombosis and myocardial infarction. Rapid occlusion does not allow time for collateral circulation to develop, resulting in ischemia, infarction, and tissue necrosis. If this series helped you, make sure to watch the previous parts to reinforce all concepts and complete the full review. For more high-yield content made simple, stay connected with Easy Medicine. Welcome back to Easy Medicine. This is the final part of our high-yield cardiology case series, where we will cover key concepts on stroke mechanisms and coronary artery disease adaptations. Let's finish strong. Case 5. A 37-year-old woman is brought to the emergency department after developing sudden-onset right arm weakness and difficulty speaking. She has no medical history but takes oral contraceptives. She has decreased strength in the right upper extremity and expressive aphasia. Cardiac auscultation is normal. Magnetic resonance imaging of the brain reveals an acute infarction in the left frontal lobe. Further evaluation with echocardiography is performed. Agitated normal saline is injected into a peripheral vein, and bubbles are seen passing into the left side of the heart. The question is, what is the most likely cause of this finding? The correct answer is incomplete fusion of the atrial septum primum and secundum. This patient had a cryptogenic stroke, which is evaluated using a bubble study to identify right to left intracardiac shunts. The test involves injecting agitated saline intravenously and observing for microbubbles in the left heart. Detection is improved with a Valsalva maneuver, which increases right atrial pressure. Cryptogenic stroke is frequently associated with atrial septal abnormalities such as patent foramen oval. During fetal development, the foramen oval allows blood to flow from the right atrium to the left atrium. After birth, changes in pressure cause closure of this opening as the septum primum is pushed against the septum secundum. Over time, fibrosis leads to permanent closure. However, incomplete fusion occurs in approximately 25% of adults, resulting in a patent foramen oval. Case 6. A 69-year-old man comes to the clinic due to squeezing pressure in his midline chest and neck that occurs when walking. He has hypertension and type 2 diabetes mellitus. He is an ex-smoker with a 20-pack year history. Coronary angiography shows extensive atherosclerosis and near-total occlusion of the left anterior descending artery. Despite this, he has a normal resting left ventricular ejection fraction and no regional wall motion abnormalities. The question is, what explains the absence of myocardial necrosis and scarring? The correct answer is slow growth rate of the plaque. In response to progressive reduction in blood flow, ischemic myocardium releases growth factors such as vascular endothelial growth factor, which stimulate the development of collateral vessels. In this patient, the slow development of a stable atherosclerotic plaque allowed collateral vessels from the right coronary artery to supply the myocardium distal to the occlusion. Because hydrostatic pressure distal to the occlusion is low, a pressure gradient facilitates blood flow through these collateral vessels. In contrast, unstable plaques are more likely to rupture suddenly, leading to acute thrombosis and myocardial infarction. Rapid occlusion does not allow time for collateral circulation to develop, resulting in ischemia, infarction, and tissue necrosis. If this series helped you, make sure to watch the previous parts to reinforce all concepts and complete the full review. For more high-yield content made simple, stay connected with Easy Medicine.
You're about to test yourself on 4 high-yield cardiology cases that show up again and again on exams like Step 1. In this video, you'll learn how to recognize stable angina in seconds, understand shock management and central line anatomy, master a classic pharmacology trap with epinephrine and beta blockers, and identify the earliest lesions of atherosclerosis before they become life-threatening. This is Easy Medicine, where high-yield concepts are made simple for fast, clinical thinking. Let's get started. Case 1. A 52-year-old man comes to the office due to periodic substernal chest heaviness. The pain is precipitated by fast walking, especially uphill and against the wind, and remits after 5 minutes of rest. The patient has a history of hypertension and smokes a pack of cigarettes a day. Blood pressure is 140 over 80 millimeters of mercury, and pulse is 80 beats per minute. The lungs are clear to auscultation, no heart murmurs are heard, and there is no peripheral edema. Which of the following pathologic states is most likely to be present in this patient? The correct answer is atherosclerotic plaque, obstructing 80% of the coronary artery lumen, with no thrombus. This patient has multiple risk factors for coronary artery disease, including age, hypertension, and smoking. His symptoms of intermittent substernal chest heaviness are consistent with stable angina pectoris. Stable angina is characterized by substernal or left-sided chest pressure, tightness, or pain that is reliably produced by exertion and relieved by rest. It occurs due to temporary myocardial ischemia, resulting from a mismatch between oxygen supply and demand. Myocardial oxygen demand is determined by heart rate, blood pressure, afterload, left ventricular end diastolic volume, also known as preload, and cardiac contractility. Myocardial oxygen supply is determined by coronary blood flow. In stable angina, the mismatch results from restricted coronary blood flow due to a fixed atherosclerotic lesion that obstructs greater than 70% of the coronary artery lumen. This lesion allows sufficient blood flow at rest, but insufficient flow during exertion. In this case, there are 2 similar answer choices, one describing 50% obstruction and another describing 80% obstruction of the coronary artery lumen both without thrombus. The correct answer is 80% obstruction, because stable angina typically occurs with significant luminal narrowing greater than 70%, without acute plaque rupture or thrombus formation. Case 2. A 55-year-old man is brought to the emergency department due to shortness of breath, productive cough, and confusion. In the last week, he was diagnosed with influenza, and his symptoms have progressively worsened. Temperature is 39.4 degrees Celsius. Blood pressure is 80 over 50 millimeters of mercury. Pulse is 120 beats per minute, and respiratory rate is 22 breaths per minute. Pulse oximetry shows 86% on room air. The patient is obtunded and in respiratory distress. He is intubated, given a 2-liter bolus of normal saline, and started on broad-spectrum antibiotics after blood cultures are obtained. A central line is placed to access structures embryologically derived from the common cardinal veins. This structure is represented by which of the following levels of the chest CT scan? The correct answer is the superior vena cava. Patients with hemodynamic instability or shock often have central lines placed into the central venous system to allow rapid infusion of intravenous fluids, blood, and vasopressors. The catheter is usually inserted into the internal jugular or subclavian vein and advanced until the tip reaches the superior vena cava. The superior vena cava is derived from the common cardinal veins. On CT imaging of the upper thorax, it is located to the right of the heart, posterolateral to the ascending aorta, anterior to the right pulmonary artery, and just below the level of the carina. All veins in the developing embryo ultimately drain into the sinus venosus, which empties into the primitive atrium. Early in development, veins are divided into 3 groups: umbilical, vitelline, and cardinal veins. The umbilical veins degenerate, the vitelline veins form the portal system, and the cardinal veins form the systemic venous circulation. Case 3. In this experiment, researchers are evaluating how a drug, referred to as drug A, modifies the hemodynamic effects of low-dose epinephrine. 2 groups of healthy volunteers are studied. The first group receives only low-dose epinephrine. In this group, epinephrine causes an increase in heart rate and a decrease in diastolic blood pressure over time. This occurs because, at low doses, epinephrine predominantly stimulates beta receptors. Activation of beta-1 receptors in the heart increases heart rate and contractility, while activation of beta-2 receptors in the peripheral vasculature causes vasodilation, leading to a decrease in diastolic blood pressure. The second group is pre-treated with drug A before receiving the same low dose of epinephrine. In this group, the hemodynamic response is different. Instead of a decrease in diastolic blood pressure, there is an increase. Additionally, the heart rate does not increase and may even decrease slightly. To understand this change, it is important to recall that epinephrine acts on alpha-1, beta-1, and beta-2 adrenergic receptors. Under normal conditions, beta-2-mediated vasodilation lowers diastolic blood pressure. However, when beta receptors are blocked, this vasodilatory effect is lost. The findings in the second group suggest that drug A blocks both beta-1 and beta-2 receptors. As a result, the beta-1-mediated increase in heart rate is prevented, and the beta-2-mediated vasodilation is also inhibited. This leaves the alpha-1 receptor effects unopposed, leading to vasoconstriction and an increase in diastolic blood pressure. This pattern is characteristic of a non-selective beta blocker, such as propranolol. Therefore, the correct answer is propranolol, because it blocks both beta-1 and beta-2 receptors, allowing alpha-1-mediated vasoconstriction to dominate when epinephrine is administered. Case 4. A group of forensic pathologists are analyzing tissue samples of adolescents aged 13 to 18 years to study the aging process. Autopsy of a 14-year-old boy who died in a motorcycle accident shows several minimally raised yellow spots on the inner surface of the abdominal aorta. The rest of the cardiovascular findings during the autopsy are unremarkable. He had no known medical problems and no family history of cardiovascular disease or sudden cardiac death. Which of the following is most likely to be the predominant cell type in these lesions on light microscopy? The correct answer is macrophages. The lesions described on the inner surface of the abdominal aorta are consistent with fatty streaks. These are the earliest lesions in the progression of atherosclerosis and can be seen as early as the second decade of life. Atherosclerosis is a pathophysiologic process that begins in childhood with focal intimal thickening and lipid accumulation. It progresses through the following sequence. First, endothelial injury or dysfunction leads to increased vascular permeability and enhanced leukocyte adhesion. Second, there is accumulation of low-density lipoprotein within the vessel wall. Third, monocytes adhere to the endothelium, migrate into the intima, and transform into lipid-laden macrophages known as foam cells. Fourth, growth factors are released by platelets, activated macrophages, and endothelial cells. Finally, there is recruitment of T cells and proliferation of smooth muscle cells, leading to extracellular matrix production. With advanced age, this chronic inflammatory process progresses from fatty streaks composed mainly of foam cells to more complex atherosclerotic plaques, including fibrous cap atheromas and fibrous plaques. If you made it through all 4 cases, you just reviewed some of the most testable cardiology concepts in a single session. But don't stop here. The next video is designed to build on this same logic with more high-yield clinical cases that will push your understanding even further. Make sure to continue with the next video in the series and keep training your clinical thinking the right way. This is Easy Medicine. Welcome to Easy Medicine. If you're preparing for Step 1 or just want to master high-yield cardiology concepts in a simple and practical way, this video is for you. Today, we're going to break down 6 high-yield clinical cases that will help you understand how cardiology concepts actually show up in real exam questions and real clinical scenarios. From athlete's heart, to congenital conditions, to heart sounds, pharmacology, myocardial infarction localization, and structural complications. This is not just memorization, this is understanding. Let's get started. This 32-year-old woman comes to the office for a preconception medical evaluation. She feels well, reports no health issues, and has had regular menstruation. She is a long-distance swimmer who recently retired from a 10-year professional career, but she continues to train regularly. She does not use tobacco, alcohol, or illicit drugs. Vital signs and physical examination are normal. In this case, we compare her with a person of similar age and sex who has a sedentary lifestyle. The question is, what cardiac changes are most likely present in this patient? The correct answer is unchanged left ventricular ejection fraction, increased left ventricular cavity size, and increased maximum cardiac output. At rest, cardiac output is approximately 5 liters per minute. During exercise, it commonly increases to 15 to 20 liters per minute. However, in highly trained endurance athletes, cardiac output can reach up to 35 to 40 liters per minute. Maximum heart rate does not significantly increase in these athletes. Therefore, the increase in cardiac output is mainly due to an increase in stroke volume. Remember, cardiac output equals stroke volume multiplied by heart rate. To meet the metabolic demands of endurance training, the body increases red blood cell mass and plasma volume, improving oxygen delivery. Skeletal muscles also develop increased capillary density, which enhances oxygen extraction and reduces systemic vascular resistance. This combination increases venous return, placing a higher volume load on the left ventricle. As a result, the left ventricle undergoes eccentric hypertrophy, increasing its cavity size and improving diastolic filling. This increased end diastolic volume is the main driver of the elevated stroke volume seen in endurance athletes. Case 2. A 1-day-old infant in the newborn nursery is found to have a harsh, hollow systolic murmur. He was born at 39 weeks to a 36-year-old mother who deferred prenatal screening. There is no family history of genetic disorders. Vital signs are normal. Physical examination reveals a flat facial profile, protruding tongue, and small ears. The question is, what most likely occurred prior to conception? The correct answer is meiotic non-disjunction. During normal meiosis, homologous chromosomes separate properly. In non-disjunction, chromosomes fail to separate, resulting in gametes with an abnormal number of chromosomes. Advanced maternal age, especially over 35, increases the risk due to factors such as oxidative stress, depletion of oocytes, and telomere shortening. The most common outcomes of maternal non-disjunction are trisomy 21, trisomy 18, and trisomy 13, in that order. Less than 5% of Down syndrome cases are due to Robertsonian translocation, typically involving chromosomes 14 and 21. Classic features of Down syndrome include flat facial profile, epicanthic folds, upslanting palpebral fissures, protruding tongue, and small ears. Congenital heart defects are present in about 50% of cases, including atrioventricular septal defects, ventricular septal defects, and atrial septal defects. Case 3. This 64-year-old man presents with chest discomfort and mild shortness of breath that began 1 hour ago after emotional stress. He has a history of hypertension and diabetes. His blood pressure is 180/100 mmHg, and heart rate is 100 beats per minute. Electrocardiogram shows no acute ischemia. On cardiac auscultation, in the left lateral decubitus position, and during full expiration, a presystolic sound is heard. The correct answer is left ventricular hypertrophy. This sound corresponds to an S4 heart sound. It occurs in late diastole, just before S1, and is caused by atrial contraction forcing blood into a stiff, non-compliant left ventricle. This generates vibration due to rapid deceleration of blood or impact against the ventricular wall. S4 is commonly associated with diastolic dysfunction and left ventricular hypertrophy, most often due to chronic hypertension. Case 4. A 45-year-old man presents with progressive shortness of breath and fatigue over 2 weeks. He has a history of non-ischemic cardiomyopathy and poor adherence to treatment. Blood pressure is 106/58 mmHg, and heart rate is 88 beats per minute. He has difficulty lying flat. Physical examination shows elevated jugular venous pressure, bibasilar crackles, an S3 heart sound, and bilateral lower extremity edema. Milrinone infusion is started. The question is, what is the most likely effect of this therapy? The correct answer is vasodilation. Milrinone is a phosphodiesterase 3 inhibitor. It increases intracellular cyclic AMP levels. In cardiomyocytes, this increases calcium influx, improving contractility. In vascular smooth muscle, it promotes calcium reuptake into the sarcoplasmic reticulum, leading to muscle relaxation and vasodilation. Venous vasodilation decreases preload. Arterial vasodilation decreases afterload. Together, these effects reduce cardiac workload. Although hypotension may occur, it is often offset by improved cardiac output. Case 5. A 51-year-old man presents with chest discomfort, dizziness, shortness of breath, and nausea that started 30 minutes ago while shoveling snow. He has hypertension and type 2 diabetes. Electrocardiogram shows ST elevation in leads I and AVL. Cardiac enzymes are elevated. The question is, which artery is most likely occluded? The correct answer is the left circumflex artery. ST elevation indicates acute myocardial infarction. Leads I and AVL correspond to the lateral wall of the left ventricle. Leads V5 and V6 may also show changes in lateral infarctions. The lateral wall is supplied by the left circumflex artery, which originates from the left main coronary artery. Case 6. A 35-year-old woman presents with progressive dysphagia to solid foods. She feels that food gets stuck in the mid-thorax. She also has palpitations and dyspnea on exertion. She has a history of rheumatic heart disease treated in India. A barium esophagram shows extrinsic compression of the mid-esophagus. The correct answer is left atrial enlargement. Rheumatic heart disease commonly leads to mitral stenosis and regurgitation. This causes increased left atrial pressure and progressive enlargement. The left atrium lies directly posterior to the esophagus. Enlargement can compress the esophagus, causing dysphagia, known as cardiovascular dysphagia. In some cases, it can also compress the left recurrent laryngeal nerve, leading to hoarseness and chronic cough. If this video helped you understand cardiology in a simpler and more practical way, make sure to subscribe and stay connected with Easy Medicine. This channel is designed to help you review high-yield medical concepts anytime, anywhere, whether you're studying, driving, or just reinforcing what you already know. And if you want to keep building momentum, go watch the next video in this series, where we continue breaking down complex topics into simple, high-yield concepts. See you in the next one.
Welcome to Easy Medicine. This channel is designed to simplify high-yield medical concepts for Step 1 in clinical learning. All content is based on official QBanks and exam-focused material, helping you review efficiently anytime, anywhere. Let's get started. Case 1. A 55-year-old man is brought to the emergency department due to severe substernal chest pain accompanied by sweating and mild dyspnea. The pain started as midline chest discomfort several hours ago, but progressively worsened to the point that the patient could not fall asleep. He received sublingual nitroglycerin in the ambulance without significant pain relief. His medical history includes hypertension, type 2 diabetes mellitus, and hyperlipidemia. Electrocardiogram demonstrates normal sinus rhythm with ST segment elevation in leads I, AVL, and V1 to V4, with deep Q wave development over the next several hours. The question is, what will cardiac catheterization most likely show? The correct answer is ruptured atherosclerotic plaque with a fully obstructive thrombus. Why? This patient has persistent substernal chest pain and electrocardiogram findings demonstrating ST elevation in the anterolateral leads, which is consistent with an ST elevation myocardial infarction. In the evolution of ST elevation myocardial infarction on electrocardiogram, peak T waves in the affected leads are typically the first manifestation. This is followed by the appearance of ST elevation within several minutes, and then Q waves within hours to days. Patients with ST elevation myocardial infarction typically have sudden onset substernal chest pain that may be accompanied by nausea, diaphoresis, or dyspnea. Importantly, the pain does not improve with rest or with administration of short-acting nitrates such as nitroglycerin. Myocardial infarction is usually caused by acute atherosclerotic plaque rupture, with release of lipids, collagen, and tissue factor into the bloodstream. Because these contents are highly thrombogenic, there is rapid formation of an overlying thrombus. In ST elevation myocardial infarction, this thrombus is extensive enough to fully occlude the coronary artery lumen, completely blocking blood flow to a portion of the heart. This leads to transmural, full-thickness infarction of the myocardial wall. In contrast, a partially obstructive thrombus is more likely to produce a non-ST elevation myocardial infarction or unstable angina. Non-ST elevation myocardial infarction is associated with impaired blood flow limited to the subendocardial region. Although the symptomatic presentation may be similar, the electrocardiogram in NSTEMI shows ST segment and T wave abnormalities without ST elevation. Case 2. A 2-day-old infant is dusky and irritable. He was born to a 22-year-old prima gravida with sporadic prenatal care. Delivery was uncomplicated, and Apgar scores were 7 and 8 at 1 and 5 minutes, respectively. His temperature is normal, blood pressure is 70/30, pulse is 148, and respiratory rate is 68 breaths per minute. Physical examination shows a cyanotic and irritable newborn with mild to moderate respiratory distress. Auscultation reveals a continuous machine-like murmur appreciated between the scapulae. Serum lactate is elevated. Echocardiogram shows the aorta lying anterior, inferior, and to the right of the pulmonary artery. The question is, what embryologic failure is responsible for this condition? The correct answer is failure of spiraling. The clinical and echocardiographic findings in this cyanotic neonate are consistent with transposition of the great arteries. The etiology of transposition of the great arteries is due to linear, rather than spiral, development of the aorticopulmonary septum in utero. This results in an anteriorly positioned aorta connected to the right ventricle, and a posteriorly positioned pulmonary artery connected to the left ventricle. As a consequence, pulmonary and systemic circulations are abnormally separated and exist as two parallel circulations. This condition is incompatible with life unless there is another coexisting connection, such as a patent foramen oval, septal defect, or patent ductus arteriosus, to allow mixing of oxygenated and deoxygenated blood. Patients may appear normal initially, but will become cyanotic, tachypneic, and tachycardic as the ductus arteriosus begins to close, typically between 1 to 3 days of life. Elevated lactate indicates anaerobic metabolism due to poorly oxygenated blood. An echocardiogram showing an aorta anterior to the pulmonary artery is diagnostic. This life-threatening cyanotic condition results from failure of the fetal aorticopulmonary septum to spiral normally during truncus arteriosus septation. Case 3. A 32-year-old man is evaluated in the emergency department due to fever, night sweats, and chills over the past several days. The patient has been using intravenous drugs recently. He has otherwise been in good health with no significant past medical history. Temperature is 38.3 degrees Celsius, blood pressure is 120/80, and pulse is 105 beats per minute and regular. Further evaluation reveals aortic valve endocarditis with an intracardiac abscess and a small fistula formation between the aortic root and the right ventricle. The question is, what blood flow pattern will Doppler ultrasound most likely reveal? The correct answer is continuous flow from the aortic root to the right ventricle. This patient has developed an aorto-ca viteri fistula, which is an uncommon complication of bacterial endocarditis. It occurs due to extension of infection from the valve into the adjacent myocardium. Echocardiography with Doppler analysis can detect and quantify shunts in these patients. During the normal cardiac cycle, central aortic pressure, approximately 120/80, is higher than right ventricular pressure, approximately 25/5, during both systole and diastole. Therefore, blood will continuously flow from the high-pressure aortic root to the low-pressure right ventricle. This represents a left-to-right cardiac shunt. Clinically, this may produce a continuous murmur on auscultation. Case 4. A 52-year-old man presents with a 2-week history of shortness of breath and dry cough. He reports decreased exercise tolerance that limits his daily activities. A Doppler probe placed at the cardiac apex reveals a flow pattern across the mitral valve. The first question is, the point marked by the arrow corresponds to which auscultation finding? The correct answer is third heart sound, or S3. The graph shows the normal pattern of blood flow across the mitral valve during diastole. There is an initial phase of rapid transmitral blood flow after the mitral valve opens, representing early passive ventricular filling, known as the E wave. This is followed by a period of minimal blood flow, called diastasis, due to pressure equalization between the left atrium and left ventricle. Finally, there is a second peak corresponding to increased transmitral blood flow due to atrial contraction, known as the A wave. The A wave ends with the first heart sound, caused by closure of the mitral and tricuspid valves. When present, the third heart sound occurs during diastole and is best heard with the bell of the stethoscope over the cardiac apex, with the patient in the left lateral decubitus position. It is caused by sudden limitation of ventricular expansion during passive filling. S3 can be normal in young healthy adults, but in patients older than 40 years, it suggests abnormal ventricular dilation, such as eccentric hypertrophy. It is commonly associated with chronic severe mitral regurgitation, chronic aortic regurgitation, or dilated cardiomyopathy. It may also be present in high cardiac output states, such as pregnancy or thyrotoxicosis. Now, the second question. On physical examination, the patient has elevated jugular venous pressure, decreased breath sounds at the right lung base with dullness to percussion, and bilateral lower extremity pitting edema. Chest X-ray shows cephalization of pulmonary vessels, curly B lines, and a right pleural effusion. Thoracentesis is performed. The question is, what pleural fluid finding is most likely compared to plasma? The correct answer is low lactate dehydrogenase. To determine the cause of pleural effusion, it is important to differentiate between transudative and exudative effusions. Light's criteria are used for this purpose. Transudative pleural effusion results from imbalance of hydrostatic or oncotic pressure. In heart failure, increased hydrostatic pressure in pulmonary circulation leads to fluid leakage into the pleural space. This produces a transudative effusion, characterized by low protein and low LDH levels compared to serum. In contrast, exudative effusions are caused by increased vascular permeability due to inflammation, infection, or malignancy. These effusions have high protein and high LDH levels. Case 5: a 44-year-old man presents for routine evaluation. He has a history of hypercholesterolemia controlled with diet. His father died of myocardial infarction at age 56, and his mother has a history of stroke. On examination, his blood pressure is 160/100, and heart rate is 70 beats per minute. He is started on enalapril. During the first 7 days of therapy, his glomerular filtration rate changes. The question is, which structure is responsible for this renal response? The correct answer is the efferent arteriole. Enalapril is an angiotensin-converting enzyme inhibitor. ACE inhibitors decrease circulating levels of angiotensin II. Angiotensin II normally causes systemic vasoconstriction, preferential constriction of the efferent arteriole, and increased aldosterone secretion. When angiotensin II levels decrease, there is reduced efferent arteriolar resistance and decreased systemic vascular resistance. Selective dilation of the efferent arteriole, combined with decreased renal perfusion pressure, leads to a reduction in glomerular filtration rate. Under normal conditions, angiotensin II helps maintain GFR by constricting the efferent arteriole. ACE inhibitors remove this effect, resulting in decreased GFR. If you found this helpful, you're exactly where you need to be. Easy Medicine is built to simplify high-yield concepts and help you master them efficiently. Subscribe and continue with the next video to keep building your clinical knowledge step by step. See you in the next session.
Welcome back to Easy Medicine. In today's high-yield cardiology review, we'll go through 6 important clinical cases focused on coronary physiology, cardiac conduction, valvular disease, congenital heart defects, arrhythmias, and pediatric cardiology. These are classic Step 1 style scenarios designed to help you understand the key concepts quickly and clearly. Let's get started. Case 1. Atherosclerotic lesions of the coronary arteries can limit blood flow to the myocardial regions supplied by the affected vessels. In some patients, certain medications can cause a redistribution of blood flow away from ischemic areas, worsening existing myocardial ischemia. The question is, which drug effect is most likely to produce this phenomenon? The correct answer is coronary arteriolar dilation. Hemodynamically significant atherosclerotic lesions, typically greater than 70% occlusion, reduce blood flow to the affected myocardial territory. In response, the myocardium releases endogenous vasodilators such as adenosine and nitric oxide. These substances dilate coronary arterioles, decrease downstream vascular resistance, and recruit additional blood flow to the ischemic region. However, arterioles supplying severely ischemic myocardium may already be maximally dilated at rest, meaning they cannot further increase blood flow. Pharmacologic stress agents such as adenosine and dipyridamole cause marked vasodilation of normal coronary vessels. As a result, blood flow preferentially increases to non-ischemic myocardium, while ischemic regions receive little or no additional flow. This phenomenon is known as coronary steal and can worsen myocardial ischemia. Case 2. A 35-year-old previously healthy man is evaluated for several episodes of syncope over the past 6 weeks. Physical examination is unremarkable, and echocardiography shows no structural heart abnormalities. During an electrophysiologic study, catheters are placed into the right and left atria to record atrial electrical activity. The patient is currently in normal sinus rhythm. Which structure is the earliest site of electrical activation? The correct answer is the right atrium, near the opening of the superior vena cava. The cardiac conduction system consists of the sinoatrial node, atrioventricular node, bundle of His, right and left bundle branches, and the Purkinje fibers. In normal sinus rhythm, the sinoatrial node functions as the dominant pacemaker of the heart and is therefore the first site of electrical activation. The sinoatrial node is located in the right atrium, at the junction of the superior vena cava and the right atrial wall. Specialized pacemaker cells within this structure spontaneously depolarize and initiate the cardiac electrical impulse that spreads throughout the atria and eventually the ventricles. Case 3. A 70-year-old man presents with exertional dyspnea. He can barely walk 2 to 3 blocks without stopping. He also reports occasional lightheadedness and palpitations. He has a history of hypertension but does not take medication. Physical examination reveals a cardiac murmur, and cardiac catheterization is performed. The question is, which point on the pressure tracing most likely corresponds to the peak intensity of the murmur? The correct answer is point B. Normally, during systole, left ventricular pressure and aortic pressure are nearly identical because blood flows freely across the aortic valve. However, in aortic stenosis, narrowing of the aortic valve creates an abnormal pressure gradient between the left ventricle and the aorta during systole. The intensity of the murmur in aortic stenosis directly correlates with the magnitude of this pressure gradient. The greatest difference between left ventricular pressure and aortic pressure occurs at point B, making it the point that corresponds to the peak intensity of the murmur heard on auscultation. The greatest difference between left ventricular pressure and aortic pressure occurs at point B, making it the point. Make sure to like, subscribe, and continue reviewing with us for more high-yield medical content made simple.
Welcome back to Easy Medicine. In today's high-yield cardiology review part 2, we'll continue with 3 important clinical cases focused on congenital heart disease, cardiac arrhythmias, and pediatric cardiology. We'll cover tetralogy of Fallot, QT interval prolongation and torsades de pointes, as well as patent ductus arteriosus. Let's get started. Case 4. A 4-month-old boy is brought to the cardiology clinic for continued follow-up of tetralogy of Fallot. The diagnosis was made prenatally during routine sonography. Despite the diagnosis, the infant has not experienced cyanosis, respiratory distress, or difficulty feeding. The parents become concerned because their son does not demonstrate the severe symptoms often associated with tetralogy of Fallot. What is the major determinant of symptom severity in this condition? The correct answer is right ventricular outflow tract obstruction. Tetralogy of Fallot consists of 4 classic abnormalities: ventricular septal defect, overriding aorta, right ventricular outflow tract obstruction, and right ventricular hypertrophy. The ventricular septal defect is usually large, allowing equal pressures between the right and left ventricles. Therefore, symptom severity depends mainly on the degree of right ventricular outflow tract obstruction. Severe obstruction increases right to left shunting across the ventricular septal defect, causing more deoxygenated blood to enter systemic circulation and resulting in cyanosis. In contrast, patients with minimal obstruction, like this infant, direct more blood toward the lungs and may appear acyanotic. The degree of obstruction can also change dynamically, leading to sudden episodes of profound cyanosis known as TET spells. These episodes may be triggered by dehydration or hyperventilation, although they are often idiopathic. Case 5. A 42-year-old man comes to the emergency department after an episode of syncope. Earlier that morning, he experienced palpitations for several seconds before losing consciousness. He reports intermittent palpitations and occasional lightheadedness over the past few weeks. His medical history is significant for chronic lower back pain following lumbar fractures sustained in a fall several years ago. Due to severe chronic pain, he has been treated with escalating doses of methadone for the past year. Which electrocardiographic finding is most likely present in this patient? The correct answer is QT interval prolongation. Methadone commonly causes prolongation of the QT interval by inhibiting voltage-gated potassium channels responsible for the delayed rectifier potassium current. This delays ventricular repolarization. Excessive prolongation of ventricular repolarization can trigger torsades de pointes, a potentially life-threatening form of polymorphic ventricular tachycardia characterized by twisting QRS complexes on electrocardiography. Patients with torsades de pointes may experience palpitations, lightheadedness, syncope, or sudden cardiac death. Methadone is especially associated with this complication because it undergoes slow and variable hepatic clearance, increasing the risk of toxic blood levels and ventricular arrhythmias. Case 6: a 12-month-old boy is brought to the pediatrician for symptoms of an upper respiratory infection. Vital signs reveal a temperature of 38.3 degrees Celsius, blood pressure of 92/45 millimeters of mercury, pulse of 110 per minute, and respirations of 25 per minute. Physical examination reveals erythema and swelling of the nasal mucosa with nasal discharge. Cardiac auscultation at the left sternal border reveals a continuous murmur along with inspiratory splitting of S2. What is the diagnosis? The correct answer is patent ductus arteriosus. The key feature in this case is the continuous murmur, which is classic for patent ductus arteriosus. Symptoms vary depending on the size of the defect and the degree of left to right shunting. Because this patient's condition was discovered incidentally and he appears clinically stable, he most likely has a small patent ductus arteriosus. Small PDAs are often identified during routine auscultation and confirmed with echocardiography. Patent ductus arteriosus classically produces a continuous murmur best heard in the left infraclavicular region, with maximal intensity around the second heart sound. Risk factors include prematurity and cyanotic congenital heart disease. Welcome back to Easy Medicine. In today's high-yield cardiology review, we'll go through classic clinical cases covering mechanical complications of myocardial infarction, autonomic physiology, shock pharmacology, heart failure, and receptor adaptation. Case 1. A 64-year-old woman presents to the emergency department 4 days after being discharged from the hospital due to chest tightness and severe shortness of breath. During evaluation, she becomes unresponsive and develops cardiac arrest. Despite advanced life support, there is no return of spontaneous circulation and she is pronounced dead. Autopsy reveals a slit-like tear in the anterior wall of the left ventricle. This finding is consistent with left ventricular free wall rupture, an uncommon but catastrophic mechanical complication of transmural myocardial infarction that typically occurs within the first 2 weeks after the event, most often around day 5. The underlying predisposition is coronary atherosclerosis leading to a transmural ST segment elevation myocardial infarction. Following infarction, the affected myocardium becomes akinetic and no longer contracts synchronously with surrounding healthy tissue, creating increased shear stress across the ventricular wall. At the same time, coagulative necrosis and enzymatic degradation weaken connective tissue integrity. Eventually, the wall may no longer withstand high left ventricular pressure and rupture occurs. When rupture develops, blood rapidly fills the pericardial space, causing acute cardiac tamponade. Patients may initially experience chest pain and severe dyspnea followed by hypotension, shock, and rapid progression to cardiac arrest. Case 2. A 60-year-old man experiences recurrent witnessed episodes of loss of consciousness while shaving. Each episode begins with a sensation of faintness followed by brief syncope lasting less than 1 minute. Blood pressure is 130/80 and pulse is 80 beats per minute with no positional changes. Cardiac and pulmonary examinations are normal. This presentation is most consistent with carotid sinus hypersensitivity. The underlying mechanism is decreased systemic vascular resistance. Normally, carotid sinus baroreceptors respond to elevated blood pressure by increasing parasympathetic output and reducing sympathetic activity, resulting in lower heart rate and peripheral vasodilation. In some individuals, particularly older men, these receptors become excessively sensitive to mechanical stimulation. Activities such as shaving, turning the head, or pressure from a shirt collar can trigger an exaggerated vasovagal response. The resulting vasodilation causes transient cerebral hypoperfusion and symptoms such as presyncope, lightheadedness, and syncope. Because cerebral perfusion rapidly normalizes, Symptoms usually resolve within 1 to 2 minutes. Case 3. A 78-year-old man with severe dementia is brought to the emergency department due to lethargy, fever, vomiting, and poor oral intake. His medical history includes emphysema, heart failure with reduced ejection fraction, hypertension, and type 2 diabetes mellitus. On examination, blood pressure is 60/30, pulse is 120, extremities are warm, and coarse rhonchi are heard over the right lower lung. After receiving intravenous fluids, the patient is started on a medication that increases peripheral vascular resistance, raises blood pressure, and lowers heart rate. The correct agent is phenylephrine. Phenylephrine is a selective alpha-1 adrenergic agonist with no direct alpha-2 or beta receptor activity. Its primary effect is peripheral vasoconstriction, which increases systemic vascular resistance and raises blood pressure. Because it has no direct cardiac stimulation, changes in heart rate occur through the baroreceptor reflex. Elevated blood pressure activates aortic and carotid baroreceptors, leading to increased parasympathetic output and reduced sympathetic stimulation. As a result, heart rate and myocardial contractility decrease reflexively. Pressor agents that increase blood pressure primarily through increased vascular resistance are particularly useful in distributive states such as septic shock. If this review helped simplify high-yield cardiology concepts, continue with the next Easy Medicine session. Consistent exposure to clinical cases is one of the fastest ways to build long-term retention for Step 1 in clinical practice. Welcome back to Easy Medicine. In today's high-yield cardiology review, we'll go through classic clinical cases covering mechanical complications of myocardial infarction, autonomic physiology, shock pharmacology, heart failure, and receptor adaptation. Case 1. A 64-year-old woman presents to the emergency department 4 days after being discharged from the hospital due to chest tightness and severe shortness of breath. During evaluation, she becomes unresponsive and develops cardiac arrest. Despite advanced life support, there is no return of spontaneous circulation and she is pronounced dead. Autopsy reveals a slit-like tear in the anterior wall of the left ventricle. This finding is consistent with left ventricular free wall rupture, an uncommon but catastrophic mechanical complication of transmural myocardial infarction that typically occurs within the first 2 weeks after the event, most often around day 5. The underlying predisposition is coronary atherosclerosis leading to a transmural ST segment elevation myocardial infarction. Following infarction, the affected myocardium becomes akinetic and no longer contracts synchronously with surrounding healthy tissue, creating increased shear stress across the ventricular wall. At the same time, coagulative necrosis and enzymatic degradation weaken connective tissue integrity. Eventually, the wall may no longer withstand high left ventricular pressure and rupture occurs. When rupture develops, blood rapidly fills the pericardial space, causing acute cardiac tamponade. Patients may initially experience chest pain and severe dyspnea followed by hypotension, shock, and rapid progression to cardiac arrest. Case 2. A 60-year-old man experiences recurrent witnessed episodes of loss of consciousness while shaving. Each episode begins with a sensation of faintness followed by brief syncope lasting less than 1 minute. Blood pressure is 130/80 and pulse is 80 beats per minute with no positional changes. Cardiac and pulmonary examinations are normal. This presentation is most consistent with carotid sinus hypersensitivity. The underlying mechanism is decreased systemic vascular resistance. Normally, carotid sinus baroreceptors respond to elevated blood pressure by increasing parasympathetic output and reducing sympathetic activity, resulting in lower heart rate and peripheral vasodilation. In some individuals, particularly older men, these receptors become excessively sensitive to mechanical stimulation. Activities such as shaving, turning the head, or pressure from a shirt collar can trigger an exaggerated vasovagal response. The resulting vasodilation causes transient cerebral hypoperfusion and symptoms such as presyncope, lightheadedness, and syncope. Because cerebral perfusion rapidly normalizes, symptoms usually resolve within 1 to 2 minutes. Case 3. A 78-year-old man with severe dementia is brought to the emergency department due to lethargy, fever, vomiting, and poor oral intake. His medical history includes emphysema, heart failure with reduced ejection fraction, hypertension, and type 2 diabetes mellitus. On examination, blood pressure is 60/30, pulse is 120, extremities are warm, and coarse rhonchi are heard over the right lower lung. After receiving intravenous fluids, the patient is started on a medication that increases peripheral vascular resistance, raises blood pressure, and lowers heart rate. The correct agent is phenylephrine. Phenylephrine is a selective alpha-1 adrenergic agonist with no direct alpha-2 or beta receptor activity. Its primary effect is peripheral vasoconstriction, which increases systemic vascular resistance and raises blood pressure. Because it has no direct cardiac stimulation, changes in heart rate occur through the baroreceptor reflex. Elevated blood pressure activates aortic and carotid baroreceptors, leading to increased parasympathetic output and reduced sympathetic stimulation. As a result, heart rate and myocardial contractility decrease reflexively. Pressor agents that increase blood pressure primarily through increased vascular resistance are particularly useful in distributive states such as septic shock. If this review helps simplify high-yield cardiology concepts, continue with the next easy medicine session. Consistent exposure to clinical cases is one of the fastest ways to build long-term retention for Step 1 in clinical practice. Welcome back to Easy Medicine. In this Part 2 high-yield cardiology session, we'll review 3 classic clinical cases covering cardiogenic shock, beta blocker withdrawal, and heart failure physiology. Case 4. A 70-year-old man presents with sudden severe substernal chest pain and shortness of breath after working outside. Examination reveals bilateral crackles and tachycardia. Electrocardiogram demonstrates ST segment elevation in multiple leads. He is diagnosed with acute myocardial infarction complicated by acute severe heart failure and started on dobutamine while being prepared for coronary catheterization. The most important physiological change caused by this medication is increased myocardial oxygen consumption. Dobutamine is predominantly a beta-1 adrenergic agonist with weaker beta-2 activity and minimal alpha-1 effects. It increases intracellular CAMP and produces positive inotropy and chronotropy along with mild vasodilation. Its powerful increase in contractility significantly raises myocardial oxygen demand. In patients with ischemic heart disease, this may worsen myocardial ischemia despite improving cardiac output. For this reason, dobutamine is not routinely used in standard decompensated heart failure but remains valuable in cardiogenic shock when restoration of perfusion outweighs the increased oxygen cost. Case 5. A 60-year-old man presents with substernal chest discomfort and intermittent palpitations. He has coronary artery disease and stable angina treated with high-dose metoprolol, atorvastatin, and aspirin. After traveling for a week, he ran out of medication and stopped taking metoprolol 2 days ago. Vital signs reveal elevated blood pressure and tachycardia. Electrocardiogram shows sinus tachycardia with mild ST segment depression. This patient is experiencing beta blocker withdrawal syndrome due to upregulation of beta adrenergic receptors. Cells adapt to prolonged receptor blockade by increasing receptor density at the cell surface. During chronic beta blocker therapy, beta receptors become upregulated to compensate for reduced signaling. When beta blockade is suddenly removed, circulating catecholamines produce an exaggerated response due to increased receptor availability. Because metoprolol primarily blocks beta-1 receptors, abrupt withdrawal results in increased heart rate, enhanced contractility, and elevated cardiac output. This rise in myocardial oxygen demand can precipitate ischemia and provoke anginal symptoms, especially in patients with underlying coronary artery disease. Case 6. A 60-year-old man presents with progressive shortness of breath, worsening exercise tolerance, orthopnea, and lower extremity edema. He has a history of diabetes, hyperlipidemia, and prior myocardial infarction. Physical examination shows oxygen saturation of 92%, laterally displaced point of maximal impulse, and significant bilateral pitting edema. This presentation is consistent with decompensated heart failure. The physiological finding increased in this patient is arteriolar resistance. Heart failure develops due to impaired systolic contraction or impaired ventricular relaxation. Both ultimately reduce cardiac output and oxygen delivery, triggering compensatory neuroendocrine responses. The body responds by activating the sympathetic nervous system and the renin-angiotensin-aldosterone system. These mechanisms increase systemic vascular resistance and promote sodium and water retention to preserve organ perfusion. Initially, these responses are beneficial, but over time they become maladaptive. Increased afterload places greater strain on the failing heart, while fluid retention produces venous congestion and reduced renal filtration, worsening the cycle of heart failure progression. If this helped simplify cardiology, continue to the next Easy Medicine review and keep building your clinical reasoning one case at a time. Welcome back to Easy Medicine. In this Part 2 high-yield cardiology session, we'll review 3 classic clinical cases covering cardiogenic shock, beta blocker withdrawal, and heart failure physiology. Case 4. A 70-year-old man presents with sudden severe substernal chest pain and shortness of breath after working outside. Examination reveals bilateral crackles and tachycardia. Electrocardiogram demonstrates ST segment elevation in multiple leads. He is diagnosed with acute myocardial infarction complicated by acute severe heart failure and started on dobutamine while being prepared for coronary catheterization. The most important physiological change caused by this medication is increased myocardial oxygen consumption. Dobutamine is predominantly a beta-1 adrenergic agonist with weaker beta-2 activity and minimal alpha-1 effects. It increases intracellular CAMP and produces positive inotropy and chronotropy along with mild vasodilation. Its powerful increase in contractility significantly raises myocardial oxygen demand. In patients with ischemic heart disease, this may worsen myocardial ischemia despite improving cardiac output. For this reason, dobutamine is not routinely used in standard decompensated heart failure but remains valuable in cardiogenic shock when restoration of perfusion outweighs the increased oxygen cost. Case 5. A 60-year-old man presents with substernal chest discomfort and intermittent palpitations. He has coronary artery disease and stable angina treated with high-dose metoprolol, atorvastatin, and aspirin. After traveling for a week, he ran out of medication and stopped taking metoprolol 2 days ago. Vital signs reveal elevated blood pressure and tachycardia. Electrocardiogram shows sinus tachycardia with mild ST segment depression. This patient is experiencing beta blocker withdrawal syndrome due to upregulation of beta adrenergic receptors. Cells adapt to prolonged receptor blockade by increasing receptor density at the cell surface. During chronic beta blocker therapy, beta receptors become upregulated to compensate for reduced signaling. When beta blockade is suddenly removed, circulating catecholamines produce an exaggerated response due to increased receptor availability. Because metoprolol primarily blocks beta-1 receptors, abrupt withdrawal results in increased heart rate, enhanced contractility, and elevated cardiac output. This rise in myocardial oxygen demand can precipitate ischemia and provoke anginal symptoms, especially in patients with underlying coronary artery disease. Case 6. A 60-year-old man presents with progressive shortness of breath, worsening exercise tolerance, orthopnea, and lower extremity edema. He has a history of diabetes, hyperlipidemia, and prior myocardial infarction. Physical examination shows oxygen saturation of 92%, laterally displaced point of maximal impulse, and significant bilateral pitting edema. This presentation is consistent with decompensated heart failure. The physiological finding increased in this patient is arteriolar resistance. heart failure develops due to impaired systolic contraction or impaired ventricular relaxation. Both ultimately reduce cardiac output and oxygen delivery, triggering compensatory neuroendocrine responses. The body responds by activating the sympathetic nervous system and the renin-angiotensin-aldosterone system. These mechanisms increase systemic vascular resistance and promote sodium and water retention to preserve organ perfusion. Initially, these responses are beneficial, but over time they become maladaptive. Increased afterload places greater strain on the failing heart, while fluid retention produces venous congestion and reduced renal filtration, worsening the cycle of heart failure progression. If this helped simplify cardiology, continue to the next Easy Medicine review and keep building your clinical reasoning one case at a time. Welcome back to Easy Medicine. Today we'll cover 5 high-yield cardiovascular and physiology cases that frequently appear on exams. We'll review pregnancy physiology, exercise adaptations, sudden cardiac death, chemotherapy cardiotoxicity, and myocardial infarction pathology in a simple and memorable way. Case 1. A 37-year-old woman, Gravida 2 Para 1, at 30 weeks gestation, comes for a prenatal visit. She reports ankle swelling at the end of the day that improves when elevating her legs but otherwise feels well. The pregnancy has been uncomplicated. She only takes prenatal vitamins and iron supplements and has no chronic medical conditions. Vital signs are normal, BMI is 30, fetal heart tones are normal, and examination shows trace bilateral pedal edema to the shins. Urinalysis shows no protein. The question is, compared with a non-pregnant state, which cardiac changes are most likely present? The correct answer is increased cardiac output, increased preload, and decreased afterload. Pregnancy requires major maternal cardiopulmonary adaptations to support fetal growth and protect against delivery-related risks such as hemorrhage. Cardiovascular adaptation includes increased cardiac output, increased plasma volume, and decreased systemic vascular resistance. Respiratory adaptation includes increased tidal volume, decreased functional residual capacity, and elevation of the diaphragm. Clinical manifestations commonly include peripheral edema, lower blood pressure, increased heart rate, systolic ejection murmurs, and dyspnea. The major driving force behind these hemodynamic changes is decreased systemic vascular resistance caused by increased vasodilators such as nitric oxide and prostacyclin, together with formation of a high-flow, low-resistance uteroplacental circulation. These changes substantially increase blood volume. Increased blood volume and reduced systemic vascular resistance allow blood to return more easily to the heart, increasing venous return and preload. Reduced systemic vascular resistance lowers blood pressure and decreases afterload. Together, increased preload and decreased afterload increase stroke volume, which becomes the main contributor to increased cardiac output during early pregnancy. Case 2. A 32-year-old woman participates in a research study and is evaluated in the hospital according to the study protocol. Her medical history includes an uncomplicated appendectomy and she takes oral contraceptives and multivitamins. During evaluation, increased heart rate and increased cardiac output are observed. Arterial blood gas testing shows normal PAO2 and PACO2. The question is, these findings are most likely part of which integrated physiologic response? The correct answer is exercise. This patient with increased heart rate and cardiac output combined with unchanged arterial oxygen and carbon dioxide levels is most likely undergoing exercise testing. During exercise, cardiac output increases to meet higher tissue oxygen demands while respiratory rate increases to eliminate the additional carbon dioxide being produced. Although oxygen consumption and carbon dioxide production rise significantly, arterial oxygen and carbon dioxide levels usually remain normal because pulmonary ventilation increases proportionally. Most changes in oxygen and carbon dioxide concentrations occur in venous blood as skeletal muscle extracts more oxygen and produces larger amounts of carbon dioxide. Case 3. A 20-year-old student suddenly collapses in class and dies despite resuscitation efforts. Review of medical records shows no significant findings except for a family history of sudden cardiac death. Autopsy demonstrates characteristic myocardial histology. The question is, complete genotyping would most likely reveal a mutation affecting proteins belonging to which structure? The correct answer is the sarcomere. Histologic findings are consistent with hypertrophic cardiomyopathy, characterized by cardiomyocyte hypertrophy, disorganized cellular architecture, and prominent fibrosis. Hypertrophic cardiomyopathy results from mutations affecting structural proteins of the cardiac sarcomere, most commonly beta-myosin heavy chain and myosin-binding protein C. Around half of cases are familial and inherited in an autosomal dominant pattern with variable expression. Hypertrophic cardiomyopathy is among the most common causes of sudden cardiac death in young adults. Although death frequently occurs during exertion, it may also occur at rest. Cardiomyocyte disarray and fibrosis alter normal conduction pathways by disrupting the spatial organization of intercalated discs, increasing susceptibility to ventricular arrhythmias such as ventricular tachycardia and ventricular fibrillation. Chronic ischemia caused by insufficient blood supply to hypertrophied myocardium further contributes to fibrosis and arrhythmogenic risk. Case 4. A 30-year-old man with advanced non-Hodgkin lymphoma undergoes chemotherapy containing doxorubicin with good response. Several weeks after his final treatment cycle, he develops progressive shortness of breath during exertion and difficulty lying flat without multiple pillows. He has never smoked and has no family history of cardiac disease. Vital signs are stable. The question is, what is most likely responsible for these symptoms? The correct answer is dilated cardiomyopathy. Anthracyclines such as doxorubicin and daunorubicin are chemotherapeutic agents associated with severe cardiotoxicity that presents as dilated cardiomyopathy. Toxicity is dose-dependent and related to cumulative exposure. Patients develop heart failure symptoms including dyspnea on exertion, orthopnea, and peripheral edema weeks to years after treatment. Anthracyclines work by binding topoisomerase II in cancer cells to create DNA cleavage complexes that lead to cell death. Similar complexes may form in healthy cardiomyocytes, contributing to toxicity. In addition, anthracyclines generate iron-containing complexes that produce free radicals capable of damaging DNA and cellular structures. The most effective preventive strategy is dexrazoxane, a chelating agent that reduces iron-associated free radical formation and inhibits harmful anthracycline topoisomerase II interactions within healthy cardiomyocytes. Case 5. An autopsy is performed on a 72-year-old man with a history of myocardial infarction. Light microscopy from the left ventricle reveals characteristic findings. The question is, when did this myocardial infarction most likely occur? The correct answer is 1 to 3 days before death. Histopathology demonstrates dense neutrophilic infiltration surrounded by relatively preserved myocytes, findings characteristic of the border zone of ischemic injury between 1 and 3 days after myocardial infarction. Cardiac muscle is highly metabolically active and vulnerable to ischemia, with irreversible injury beginning after only minutes of oxygen deprivation caused by coronary occlusion. After irreversible injury occurs, myocardial tissue undergoes predictable microscopic changes driven by coagulative necrosis and sequential infiltration of inflammatory cells. Recognizing these histologic timelines is essential because they frequently appear in pathology and cardiovascular questions. Thanks for studying with Easy Medicine. If these high-yield clinical cases help simplify difficult concepts, keep practicing consistently because repetition is what transforms memorization into long-term understanding. See you in the next session.